consultation addressed the undertreatment of pain in the United States, and he has been actively writing, teaching and speaking on the topic of chronic pain since 2000. So his lecture this morning, entitled Beyond Opioids, looks at the bioethical issues in relation to pain management. So without further ado, let me ask Dr. Goldberg to address us. Thank you.
Is this on? Can you all hear me? It's okay. I tend to bounce around a lot, so a lav mic works better. So thank you very much for the introduction. I don't really care much about the size of the crowd. I mean, full house is always nice, but those of us who are here, we'll forge on, right? So I usually like to joke, it usually only takes me one or two people and a blank wall to get me talking, so, right? So we'll forge on. So I've been working on this issue for 10 to 15 years at least, and especially now, this was true when I started working on it, but especially now, as soon as I open my mouth and I say pain, what do people want to talk about? Drugs. So we're not going to do that today. You came to a talk about pain. If you thought we were going to spend a lot of time talking about opioids, that's not true. I'm going to disabuse you of that notion. I'm going to tell you why that I don't spend tons of time talking about opioids. They're relevant, of course, but this is actually talk about pain, not about opioids. Why? So I usually always like to put the objectives up there because I teach and talk to the objectives. We've had problems treating pain for at least 50 yefor right? And here I speak as a historian of pain. Really, we've had problems treating pain for hundreds of years, thousands of years, right? But in the modern era, we've had difficulties treating pain for at least 50 years, and we've been intensively trying to address these problems for at least 50 years. So our efforts began in sort of concerted efforts, really began in the early 1970s. They've been immense, they've been cross-sectoral. We've got public, we've got private investments, we've got community investments. There are numerous professional societies devoted to the topic of pain in particular, and this has been going on since the 1970s. Lots of policy groups too, but I want to argue that we haven't succeeded. The claim that we are generally overall treating pain, especially chronic non-malignant pain, much better in general in the US as a result of these efforts, I think is unsupportable. We have absolutely staggering prevalence and incidence, and there are disagreements. Pain is a notoriously difficult illness condition to quantify and measure. But we have general estimates are just absolutely staggering prevalence and incidence, as many as a third of Americans. Some more conservative estimates suggest as many as a fifth of Americans, right? But either way, that is a very, very large number in terms of a disease burden. There's numerous studies in the last 10 years that have shown very little improvement. Furthermore, I think we can make a pretty good argument that we're actually treating pain worse than we have in the past. And how might we know this? Well, we have rising prevalence and incidence. We have increasing inequalities. Like most of our health inequalities, it looks like they're increasing in the assessment and the treatment of pain, and we can find those across different healthcare settings, right? We can track pain in different healthcare contexts, and we can see that our difficulties in assessing, managing, and treating it actually seem to be, we seem to find them in multiple different settings, right? So in emergency settings, in primary care settings, we find them, right? So, in addition, the increasing burden of chronic illness, right? The upward trajectory of chronic illness in the United States suggests that because pain is highly comorbid with most of the serious chronic illnesses we have in the US, we can expect increasing incidence and prevalence of chronic pain in the future, right? So it doesn't look like as a public health problem we're doing very well. And this is something that's very important to me as a public health person, is the understanding that pain actually is a public health problem. We tend to regard pain primarily as a clinical problem because, of course, it is a clinical problem. That's where it manifests. It's not to deny that. It is at the same time, however, a public health problem. What makes something a public health problem? Well, we look at, does it affect large numbers of people? Check. Right? Do we have intuitively troubling patterns of this illness, injury, or disability experience, right? Does it look like we have inequalities across these groups? You know, check, check, right? So it looks like it fulfills all the requirements for a public health problem. And in some of my other work, I won't talk about that much today, I've argued what would happen if we started to treat pain more like a public health problem. It's also highly, looks like it's highly connected to usual social and structural determinants of health, which is also the kind of thing that makes public health people sort of sit up and say, hey, this is something we need to be talking about, right? So I said I wasn't going to talk about opioids today. And this is why. I think we have at least two to three, I'll focus really on two of them today, but we have at least 2 to 3 different public health problems. The first problem is the safe and effective use of opioids. Now, don't run out of here saying Goldberg said that wasn't a problem. It's a huge problem, okay? It's very obviously a public and population health problem. In fact, it's so serious of a problem, as most people probably know, it's actually almost single-handedly lowered life expectancy in the United States, which is absolutely, to use my daughter's favorite word, banana pants, okay? That a single health condition could single-handedly lower life expectancy in the United States. It's actually quite remarkable. The second public health problem is the inequitable undertreatment of pain. And part of my jumping off point for talking about pain with you all and how I think about pain in general is that these are not the same problem. They're related problems. I'm not saying they're irrelevant, but what we have done for the last 40 years is try to resolve our problems in equitably treating pain by resolving our problems with drugs and opioids, right? The thinking is that if we fix our problems with drugs, we'll fix our problems with pain. And my long-running argument, and it's the main subject of today's presentation, is that this is a mistake. And there are profound reasons to think that even if these are connected problems, they are not the same problem, and that we aren't going to fix our problems with people in pain, even if we were to magically fix our problems with opioids and prescription drugs. And I'll say a little bit more in a moment about why I think that's the case. I also think that stigma, which is probably the central area of my research and scholarship over the last 5 years, stigma is a health problem. And I'll say a little bit more about stigma later today, and I'm actually speaking on stigma at the National Nursing Ethics Conference on Thursday and Friday. But stigma is actually, even when we control for almost every conceivable confounder, members of groups that are subjected to persistent stigma seem to get sicker and die quicker. Stigma is increasingly regarded by social epidemiologists as an independent social determinant of health, which it probably should be. So stigma is a health problem. It's not just we think we ought not stigmatize people, and as an ethicist, I'm here for that. I think we ought not. But it also seems to be corrosive and bad for people. So I'm going to call that a health problem too. So why do I argue this? What's my basis? What's my justification for thinking that these are different? That our problems with opioids are not the same problem as our problems with pain, even if they are related. Can I lower this? Okay. So the first reason is based on sort of clinical science and epidemiology, right? How did we get into so much trouble with opioids? And I know we're in the third wave of what's going on with substance use, right? It's more now an illicit street drug problem than it was in the first wave and closer to 2010. But how did we get into this problem? Well, part of the reason we got into this problem is because the evidence, the strength of the evidence for the safety and efficacy of opioid use, of long-term opioid use for chronic non-malignant pain is what? You should put your finger to your nose. It's not good. It's poor. It's bad. Okay, so here's what I say. Let's do a thought experiment. Let's say we were perfect risk calculating machines. We knew ahead of time the risks and benefits for every potential person for whom opioids might or might not be prescribed, right? So in such a case, of course, we would only prescribe opioids for people for whom the benefits significantly outweighed the risks, right? And we would never prescribe opioids for people for whom the risks significantly outweighed the benefits. And we had perfect information in my thought experiment. We know this in advance, right? So I asked, let's say we did this and we lived in this utopian world, what would we still have? And the answer is we'd still have millions of people in chronic pain, right? Because while there are some people with chronic non-malignant pain who probably do benefit from opioids, it's a much, much smaller group than we used to think it was, right? So even if we could perfectly fix all our problems with prescription drugs and opioids, we'd still have millions of people walking around with pain. Right? It wouldn't solve that problem. So even fixing our problems with drugs and opioids would still leave huge, huge numbers of people with persistent chronic pain. It's not going to fix that problem. So there's no good reason based on clinical and epidemiologic science to actually think that going through drugs and opioid policy is a good way to fix our problems with treating people's pain equally. That's not true. There's no reason to think that way. The second category of reasons I think that these are distinct problems are what I call conceptual reasons, right? So one cohort in the US whom we seem to have a particular problem with treating well in terms of their pain are geriatric populations in the US. The estimates of prevalence and incidence of pain in geriatric populations are absolutely staggering. Again, pain is difficult to measure, but especially for those who are actually residing in long-term care facilities, there are prevalence estimates of 60 to 80%. And even if that's an overstatement, you can probably guess that it's still a pretty high prevalence and incidence, right? We do not do a good job of treating geriatric people's pain, geriatric population's pain. Why not? Well, the researchers have looked into this, and although there are a number of factors, the most compelling factor, the biggest reason, seems to be that elderly people in the US don't report their pain. Which, if you know anything about treating pain, that's going to be a problem, right? That's day one stuff in any kind of handbook on pain management. Says that the patient's subjective self-report is the single most important tool we have for assessing, diagnosing, and treating pain effectively. So if people don't tell you they're in pain, it's going to be hard to treat their pain well. And we don't treat their pain well. Well, here's the question. Why don't elderly people report their pain? And as far as we can tell, the answer has very little to do with opioids. Elderly people tend to underreport their pain, at least the biggest reason, although there are multiple factors. The biggest reason that's been reported in the literature is that elderly people tend to see pain as a stalking horse for death. Where pain comes, the four horsemen of the apocalypse ride right behind it. And so, quite understandably, people in this position they don't want to talk about their own mortality. Who does? Of course, right? So they don't talk about their pain. And so here's my question for you all. What does that have to do with opioids? And the answer is, as far as I can tell, almost nothing. In fact, as a cohort, geriatric people in the US want opioids less than almost any other identifiable patient cohort that we can find. Right? Geriatric populations in the US tend not to want, or ask for opioids. As a cohort. I'm not saying that's true of every individual, of course, but as a cohort, that's what we tend to find, right? So why do we treat pain poorly? It has to do with what pain means in these communities, in families, in networks. It has to do with what David Morse called a culture of pain. It's not about opioids. We're not going to fix that problem through drug policy. Certainly not through supply-side restrictions on opioids, okay? So that's the second set of reasons. Is some of the reasons, at least some of the significant reasons why we tend to treat pain poorly, really don't look like they have a whole lot to do with drugs and opioids. And the third set of reasons that I usually talk about are historical, right? And again, here I speak as a historian of pain. We've tried it for over 40 or 50 years, and it hasn't worked. It doesn't work. That's what we've been doing. We've been trying to fix our problems with pain with opioids, more, less, and in fact, if you actually go to historians they're called drug historians or historians of opioids, they can document this for 100 years, not just 50 years. Right? So this approach by trying to resolve our difficulties with treating people in pain through opioids, even on the policy level, just hasn't worked. And I think it's probably my argument is that we should probably try something different now. So if this is not why we treat pain poorly, if it's not just about opioids, what is it about pain that makes it so difficult to treat? So usually I'll ask clinicians, and I'm not a clinician, which is part of the reason I like to talk to clinicians, because y'all tell me if what I'm saying makes any sense with your practice life or not, and that's a useful check for me. But a lot of times, I'll hear the response that it's subjective, right? Which I think is a very interesting expression, because usually what I follow up and say, well, so is nausea, right? Nausea is subjective. There's no test for nausea, no blood test, no imaging, right? Why do we treat nausea well, or better at least, and not pain, right? And the suffering that people report with nausea is actually significant, right? Intense nausea is comorbid for suicidality, actually, right? So it's an interesting thing. So this is sort of my approach, my theory behind this. I'll sketch a little bit of this out today, and we can talk a little bit more if you want in the Q&A about this. But there are many possibilities as to what pain means and why we treat it so poorly, the ambiguity of pain. Emily Dickinson once famously wrote that pain has an element of blank. That's the first title of her poem. It's a great poem, actually, right? And even if you don't like poetry or Emily Dickinson, it's surprisingly accessible for an Emily Dickinson poem, right? So if you Google that, you'll find it. Pain has an element of blank. There are concerns of stigma and punishment. The Latin root for the word pain is poine, which actually means punishment. So we'll talk a little bit more about that later. But the particular cause that I've been sort of invested in exploring in some of my work is what I refer to as the power of the material, the visible pathology in American cultures of biomedicine, healthcare, and science. What does that mean, right? So that doesn't mean anything yet. So let's explain it, right? So Western allopathic medicine, and I would say healthcare in general, although healthcare and medicine are not the same thing, the kinds of education that people in the health professions undergo in the US strongly tracks the kinds of education that have traditionally developed in the modern era for medicine as well. So even though these aren't the same thing, there are tight connections between these, right? And Western allopathic medicine, the name of it, what is generally referred to as the anatomo-clinical method, or the clinico-pathologic method, right? So it's actually based on anatomical learning. There is a reason why most health professions actually start with a basic grounding in anatomy, right? Even though there's debate among, for example, medical schools in the US about whether or not you really need 12 weeks of gross anatomy with a cadaver anymore, or 8 weeks or 9 weeks. And in fact, it's decreased. It's still the beginning. It's still the beginning for almost every medical school in the United States. Why is that, right? So anatomy is ancient, of course, but it actually didn't begin to define Western allopathic medicine until the 19th century. The British Anatomy Act of 1832 actually said that you could not claim to call yourself the practice of physic a physician unless you had a certain amount and a certain number of hours of anatomical training, right? So there's a focus on what I call the twin sons. These twin sons, pathological anatomy and clinical correlation. What does that mean? Well, pathological anatomy, the effort is to see, to make visible the material pathologies that we can find inside the body. And then, of course, there's an effort of clinical correlation, right? It's not just enough to find morbid pathologies, right? We have to be able to correlate them clinically with the illness complaints that the patient is experiencing, right? Here, when we're talking about anatomy, when was the patient experiencing them? When they were alive, because hopefully by this point it's a postmortem, right? Hopefully we're not doing vivisection back at this time. Although, for those of you who know something about the history of anatomy, that was actually a real problem, right? And you can Google the Burke and Hare murders if you're really interested in finding out more about that, okay? So there's this focus on pathological anatomy and clinical correlation. It's most famously articulated by Foucault, and I won't beat anybody over the head with Foucault, but he basically says the appearance of the clinic as a historical fact is indicated by the minute but decisive change whereby the question, what is the matter with you, with which the 18th century dialogue between doctor and patient began, was replaced by that other question, where does it hurt? It's about localizing. It's about localizing the patient's illness complaint to a particular morbid pathology, right? And for most people who practice healthcare in the US today, usually we can see most of that today. That's still generally what happens, right? There are reasons why I study both pain and medical imaging. I think those two are highly linked, right? For example, one of the most common illness complaints in the US among middle-aged white men is chronic low back pain, right? And at least traditionally, there's some signs it's starting to change a little bit, but traditionally, if you would present to a healthcare provider in the US with a complaint of chronic low back pain, what would happen? Right, have it x-rayed or imaged or MRI or something. You'd proceed to imaging, right? It's almost exactly what would happen. And that's just an example, but there's lots of different examples of that. Perhaps not surprisingly, we have what's called hyperutilization of medical imaging. We love the shiny in the US. I think you know that. We love our healthcare technology. It's like the precious, for those of you who are Lord of the Ring fans, okay? But even with our general rates of increase in the use of technology, our use of imaging is actually growing. It's slowing down now, but it has for many years grown at a higher rate. We do a lot of medical imaging, okay? And I think this has something to do with it, right? So Rosalind Ray talks about this. Rosalind Ray is she's deceased now, but she was a historian of pain, and she says, look, at the dawn of the 19th century, physicians were looking for a pure sign, which would remove the ambiguities inherent in symptoms. They wished to find a sign, the meaning of which would be as certain as that provided by the lesion found at dissection. I've actually used this quote a number of times in working with providers who treat people in pain, and if I take out the first clause, they say, yes, when was this written? Right, at the dawn of the 19th century. If I take that out, there's people who still say that's part of the difficulty in treating pain, right? So this idea behind the clinical pathologic method is not to discredit it or to critique it. The clinical pathological method has done a lot of good for a lot of people, and it continues to do so. Part of the problem, however, and this is sort of my argument, is that what anthropologists have referred to as the family of contested illnesses don't fit very well into the anatomo-clinical method. It is difficult to objectify and find morbid pathologies for many kinds of chronic illnesses which actually don't have these kinds of pathological or anatomical signs. For many people, though there's lots of different kinds of chronic non-malignant pain, for many people who experience chronic non-malignant pain, this is their lives. Right? There aren't solid tumors that we can connect to this. There aren't pathologies. For people with neuropathic pain, they had mechanical trauma that healed, and neuropathic pain just continues endlessly, right? Even though we can't actually find any kind of tissue damage with which we could clinically correlate this illness complaint, right? So this is the kind of argument. So my belief is that if these things can't be seen via objective instrumentation, then pathological anatomy and clinical correlation is frustrated. It's frustrated. It's not just about pain. There are other kinds of illness complaints, right? One of the most memorable examples, I think, was what's now being called myalgic encephalitis, used to be called as chronic fatigue syndrome. What was really interesting is about 7 or 8 years ago, the NIH had a small conference for my MYE-CFS, myalgic encephalitis. And the purpose of the conference was to debunk the virus theory for the etiology of chronic fatigue syndrome, right? A lot of people who had CFS, there was some preliminary evidence that suggested it might be caused by a virus. So they did a bunch of research, and at this conference, they were all scheduled to present their findings, which documented the idea that it almost certainly was not. The etiology was not, at least not, it might be viral, but not this virus in particular. What was really interesting is that you had picketers. And I know this is the day where we're talking about picketers, so let's carry on the theme, okay? Right? They actually had people, advocates, patient advocates, people who had MYE-CFS actually picketing the NIH. Why? Right? That's not the first place I think of industrial action, I guess, right? And part of the answer is because, again, being able to find this kind of objective instrumentation, right, this kind of actual objective pathology with which we can clinically correlate is super important. It's encoded into our society and culture, right? Who wants medical imaging? Who wants it? Who desires it? Why do we do so much? Because we do a lot of medical imaging. Why do we do so much? Who desires it? Well, what's that? Patients want it. Most people, we know, the single most important factor in determining utilization of healthcare resources in the US, far and away, is supply. That's been shown for over 60 years by health economists. If we haves it, we uses it. Right? So the single most important factor in determining hospitalization is beds. If we have beds, we put people in them. Right? If we have fancy imaging devices, we use them. Right? And if you don't, by the way, you'll get a visit from the hospital purchasing agent reminding you of the cost of these nice imaging units. Okay? So supply is a huge factor, but what's really interesting is when we talk about medical imaging and when we talk about pain in particular, demand is a huge part of it as well. Patients want it. They want it. Why? Why do patients want imaging? Why is it so important to them? They want to find something. They want to see something. Why do they want to see something? They want a reason. They want something because this idea, right, this idea of sort of an objective material pathology that we can clinically correlate with illness complaints, even though it is a medical and scientific idea, it isn't cabined, right, to sort of expert communities. This is how many people in Western society, many people in the US society come to think about the terms and make meaning of their own illnesses. And of course, many chronic pain sufferers have been deeply stigmatized for many years as a result of their pain experiences, right, which we're going to move to in a moment. And so this makes it even more likely, right? So part of the problem is, and this is where I've sort of been directing a lot of my work over the last 5 years, is if we can't find those pathologies which we can clinically correlate with illness complaints, which, like I said, is not just about pain. There are other kinds of ones, MIE, CFS, PTSD used to be one of these, a contested illness, and that's the idea, that's the phrase. They are called contested illnesses. It's been called in the literature diagnoses you have to fight to get for many people, okay? Right? And so part of the problem is that it looks like these contested illnesses make people who experience them much more likely to be subjected to stigma. And that stigma tracks all sorts of troubling fault lines, right? Race, gender, class. So I'm going to say a few things about stigma. And then we'll probably wrap up and have some time for questions, okay? So one of the things I think is most important when we talk about stigma, and I'll be talking about this a little bit more on Friday at the NNEC this week, is most people actually don't have a good concept of what it actually is. When I ask what stigma, usually people say, well, they'll give me an example. They'll say, you know, it's when, or it's when this happens, or they give examples, and that's fine, but I actually think it's useful to define stigma because we get a number of important things about it, especially when we want to talk about pain. So there's two components of stigma, and this tracks Bruce Link and Joe Phelan's conceptual framework. The first is you have to have an in-group that marks an out-group as different on the basis of a shared demographic characteristic. So I say that fast, okay? You have to have an in-group that marks an out-group as different on the basis of a shared demographic characteristic. Can we give me an example? What's a characteristic by which we mark people? Age? Yeah. What else? Skin color. Sex, gender? Yeah, absolutely, right? Notice that most of these things are visible, which is interesting. Visibility is part of the component of stigma. This is called the marking phase or the branding phase. That's not enough for stigma. It's not just enough to mark a group as different. Right? Then the in-group has to assign a notion of deviance to the out-group on the basis of that shared demographic characteristic. There has to be something wrong with the out-group on the basis of that shared demographic characteristic. So this is it. Difference plus deviance. That's usually how it's referred to as stigma, right? One of the long-standing slogans of the disability rights community has been difference without deviance. Right? Disabled people know what stigma is, right? And so the basic idea is just because we are a group that may have different functionings and capabilities does not mean we should be judged as inferior or deviant on the basis of that. So this is it. That's stigma. Difference plus deviance. I think, though, we get a number of really interesting and important things that flow from it. The first is the idea that stigma is actually a creature of inequality. And this is relevant for pain sufferers. We'll come back to pain in a minute, okay? But stigma is actually a creature of inequalities. How do we know that? It actually inheres in the definition. An in-group marks an out-group is different on the basis of a shared demographic characteristic. The in-group has to be, it's actually in the title, in. The out-group is out. So are you all members of in-groups or out-groups? Yes is the right answer. Right? Social life is complicated. Most of us are members of multiple in-groups and out-groups all at the same time. The important question for thinking about stigma and pain, though, is what happens if you belong to multiple out-groups? The more multiple out-groups and very few in-groups, right? And what we would predict, what we would say, is that people who are multiply marginalized, multiply disadvantaged, they are much more likely to experience stigma before they even set foot in a clinical setting. Right? And that's what we would predict. And in fact, the empirical evidence actually bears that out. By definition, stigma is linked to social power structures. So, unsurprisingly, the evidence also suggests that disease or health stigmas that patients experience are also distributed highly unequally. Some kinds of people are much more likely to experience stigma, including pain stigma, than others. One of the interesting things about pain stigma is, although all of the qualitative evidence suggests it's distressingly common, and as a stigma scholar, I would go so far as to say it might be one of the most common forms of health stigma that people experience. We actually have almost no good epidemiologic data on pain stigma. So I and a team of people at the University of Colorado are working on fixing that, okay? Because we are trying to actually get some measurements, an instrument for measuring pain stigma, and then actually trying to generate some preliminary evidence of the epidemiology of it, the prevalence and incidence, right? But what we know is that these other kinds of disease stigmas are distributed highly unequally. Okay, so I promised in the learning objectives we would talk a little bit about social justice, and this is where we'll get to that part today. So stigma is fundamentally connected to power structures, and disadvantaged and vulnerable people they're both more likely to be stigmatized, prevalence and incidence, right? But we also want to talk about the severity of the stigma and the consequences, the social consequences of experiencing that stigma are more likely to be severe for more marginalized patients. So this is what people in pain are dealing with, right? And so, there's a multiplier effect, which we see with other kinds of social inequalities in the US, right? If you are a straight cis-het white man like myself, right, you are less likely to be stigmatized for your pain than if you are a straight cis-het woman, right? Who's more likely to be stigmatized, and then you can keep going down if you are a person of color, if you are a disabled woman of color, if you are a disabled woman of color, an elderly woman of color who lives in a rural setting, et cetera, et cetera, et cetera. It's not linear this way. We're talking about likelihoods at the cohort level, the probabilities at the cohort level, but this is generally what we find, right? And so these things tend to be connected to these kinds of compound disadvantages. Stigma is both an effect of multiple marginalizations belonging to multiple outgroups, and it looks like it's also a cause of it. It actually continues to drive disadvantage as well. It continues to ensnare people in what Madison Powers and Ruth Faden call densely woven patterns of disadvantage, which I think is a really nice metaphor for thinking about these kinds of things, okay? And the problem is that once you are ensnared in a densely woven pattern of disadvantage, escape becomes extremely difficult, right? And that's partly why people who work on public health policy, which I do, one of the things we talk a lot about is the danger of stories. Stories are great, but for every one person who escapes a densely woven pattern of disadvantage, there are going to be 20 or 30 who don't. And given what we know about the power of these kinds of social structures, it's probably not because most of those people aren't trying very hard. We don't have a lot of good evidence for that. That's my editorialization, but, right? What else do we know about pain stigma and disease stigma, right? So one of the things we know about it is that it's hegemonic. Hegemonic is a fancy humanities word. It just means it's everywhere. It's all the time. We don't even see it, right? The metaphor I'll use to describing the way that this works is it's like the backdrop on a play, right? Anyone who knows anything about stagecraft will tell you that the background of a drama, a musical, a play is hugely important in how the audience interprets what's going on. It sets tone, it helps shape meaning, and all these kinds of things. It's super, super, super important. And yet one of the things we find is that over time, what happens if you're watching a musical or a play, you actually stop seeing the background. It fades because what you're focusing on is what's happening in front of you with the characters, the plot, the music, whatever it is. But the key is that it's still there. It's still exerting a huge influence in what's going on and how you're interpreting it. So for example, Australian healthcare providers, I like these twin studies, I think they're interesting. These investigators surveyed Australian healthcare providers in 2013 about type 2 diabetes. And they said it's one of the least stigmatized conditions. Then they asked the patients. And 93% of them reported experiencing some kind of stigma, right? So that's the way that stigma can be hegemonic. And that's type 2 diabetes. It's not pain, but we find the same kinds of things when we look at most other kinds of chronic illness stigmas, right? So I think, it's especially helpful for us in thinking about pain and stigma, right, and opioids. There's a lot of people who experience chronic pain, a lot of people. Right? And they're not all the same, and we can find differences, and it's actually quite common. There are many chronic pain sufferers and chronic pain patients who report that they have no interest in opioids. They don't desire them, they don't ask for them, they don't want them. There are, of course, many who do, but there are also many who don't. And it's clearly not the case for what we know about stigma. And again, we don't have great quantitative estimates of stigma, but we don't have any evidence, we have good qualitative evidence, and we don't have any evidence that would suggest that pain stigma is somehow cabined or limited to the class of pain sufferers who are desiring, taking, or for whom opioids are indicated. There's no reason to think that's the case. Pain stigma seems to travel with people who experience pain. Doesn't track neatly on people who want or don't want opioids, take or don't take opioids, or do not have opioids indicated for them, right? So again, more reasons to think that we're not going to fix our problems with pain, we're not going to fix our problems with stigma by working on opioids. And we also know that stigma is apparently common even in illnesses where misuse is relatively low, right? And the classic example there is in sickle cell disease. Now, why would we have such a concentration of pain stigma among patients with sickle cell disease? You know why? Because they're people of color, because they're black. Mostly, not all people who have SCDR, but that's where it's most prevalent, right? Opioid misuse is quite low among this population, right? Relatively speaking. So what does this have to do with social justice? So the term social justice gets thrown around a lot, and personally I don't like that because I think social justice is too important to be reduced to a slogan, to be honest with you. Which is usually what happens. And here I argue with my public health people, and public health people are my people. So when I'm yelling at them, I'm yelling at them as an insider, not an outsider. Okay. But as near as I can tell, when I get in a room of public health professionals, social justice, the criteria for social justice is whatever I think is good. And actually, there's a lot of shared values among public health people in the US. So actually, 80% of us in a room pretty much have a very similar sense of the things that we think are good. And so it's like a big happy party, and we all get along, and that shared sense of value is great, except for what happens when you come across people who do not share your priors and have that same sense of value. So for example, we have excellent health communications research on what the word social justice codes for in more politically and ideologically conservative communities in the US. I have a public policy background. I invite you to go to the legislature of a red state and start talking about social justice and see how far that gets you. Okay? It's not going to get you anywhere. Okay? In fact, quite the contrary. It's going to get you shown the door is what it's going to get you. Okay? So it's not a slogan. We can put some meat on the bones, though. And there are some rigorous theories of social justice. The one that I prefer to work with the most comes from Madison Powers and Ruth Faden, perhaps not surprisingly because they are public health ethicists. And their idea of social justice is very strongly rooted in the same kinds of social epidemiologic evidence bases that I like to work. And so they have this health sufficiency model of social justice. We won't talk about it extensively today because that's not going to help anybody, and I don't like talking too much about theory. But one of the things they focus on are inequalities. Right? Most people think that lots of health inequalities are bad, but there are some important questions there because, first of all, not every inequality is bad. So I'm going to tell you that there is a stark difference, there is a stark inequality in basketball talent between myself and LeBron James. Right? And you're all laughing, and no one cares about this except me. I do care about it, by the way, but no one else should care. Right? It's not a matter of moral concern. Or what if I tell you we have stark gender-based inequalities in prostate cancer screening? Not a problem. Well, probably not a problem, right? I don't think it's a problem, okay? So first of all, not all inequalities are unjust. And then second of all, even among the ones that strike us as intuitively unfair, we think that there's a problem with it, we still need some way of rank ordering them, right? Which inequalities are the worst? Which ones should we focus on? It's not a false choice. We can focus on multiple inequalities at the same time, but we can't focus on all of them with the same degree of investment and attention. Right? We need a choice, okay? We need a way of rank ordering them. And Madison Powers and Ruth Faden's model of social justice gives us a way of thinking about this. They say we should focus on the inequalities that fuel those densely woven patterns of disadvantage. Those are the worst ones. Those are the ones which keep people trapped in cycles of inter- and multi-generational deprivation and marginalization. Those are the ones we should focus on, okay? And they have a whole big argument for why that's the case. But they say we should really do two things. We should focus on improving overall population health, and we should focus on compressing inequalities, and we should try to do them at the same time. And that's actually a catch. We're not so good at that in the US. We tend to focus more on the first one and not the second one. We tend to work really hard to improve overall population health, even in ways that expand health inequalities, and the classic example of this on the population level is smoking. Right? We've drastically reduced the incidence of tobacco consumption in the US over the last 15 years. This is a good thing. Don't run out of here saying Goldberg said that was a bad thing. That's a great thing, okay? But at the same time, what's happened to the gradient of smoking? Who smokes now? It's poorer people who smoke. It used to be pretty flat. It used to be rich and poor people that smoke. But now, it's mostly poorer people who smoke, which means that even though, as a whole, we've improved our population health, we've lifted everybody up, the gap, because of smoking-related disease, between the least well-off and the most well-off has actually increased. It's actually increased with regard to smoking, okay? So that's not to say we shouldn't try to get people to quit smoking. We should. But Madison Powers and Ruth Faden's theory suggests that we really should focus on both of these things, right? And that we really need to focus on policies and practices, right, that reduce both pain, the burdens of pain, because it looks like it intensifies all of these kinds of inequalities and differences, and the stigma that so commonly attaches to pain. It fails both of these prongs. Stigma is a creature of inequality, which means that people who are more marginalized are more likely to experience pain stigma, and it's corrosive and bad for your health. Right? And I'll talk more about this on Friday for those of you who are interested or who are coming. Okay? So we're going to go through this pretty quickly. Because stigma is hegemonic and it exists in the background, right? People often stigmatize others even when they don't intend to. And this is one of the hard things for people to understand. I don't think stigma is a funny thing, because usually we give talks on bioethics, about whether or not we should withdraw life-sustaining treatment. And if I ask for a show of hands, half of you would say yes, and half of you would say no, and we have a big old ethics debate, right? But stigma is funny because I don't generally give talks in ethics context where I have a whole bunch of people up in the room saying yes, we ought to stigmatize people. And when I get up in the morning and I think about helping my patients, that's the first thing on my list is I think, how can I stigmatize my patients today, right? Nobody really seems to think this is a good idea, and yet what we understand when we look at it is it's still pretty highly prevalent. So how does this happen, right? People don't necessarily intend to do it. And I like this idea of social scripts, right? That stigma is deeply rooted in these upstream macro-social structures, right? And I'll give lots more examples a little bit in the talk on Friday about how this happens, about how our behavior is scripted in ways, even in invisible, unintentional ways. The examples I usually give are, let's say you walk into a clinic and the intake form just has 2 boxes for gender. Do the people there hate gender, non-binary, gender fluid, gender queer, transitioning people? I hope not. Maybe, it's possible, but particularly in Southern California, probably not. Okay, to be honest with you. And yet, right, what's the message that's actually sent to that person, right? Which is really, there's not a good space for me here, right? Or the other example I give is when you walk into a clinic waiting room, if you're a fat person, and I use the word fat, by the way, with a capital F. So I do some work with fat stigma and fat activists and fat studies scholars, and many members of these communities, although I have thin privilege, many members of these communities actually prefer the term fat to obese. You don't have to agree with me, and it's a whole separate conversation, but just don't flip out when I actually use the term fat, because a lot of people do, okay? So I'm using the preferred term from a lot of members of these communities, right? So, but when a fat person walks into a clinical waiting room and all of the chairs look like this, right? I'm going to presume that no one in the clinic actually intentionally hates fat people or set out to stigmatize fat people on that given day, and yet the message is still the same. There's no place for me here, right? I'm an out group, I don't belong, right? And so these are the ways in which these kinds of social scripts can change our behavior, change the way we react. And they're often, what's more problematic for me as a public health law scholar is they're often integrated into laws and policies. So here's a classic example. In the Code of Federal Regulations that governs entitlement to Social Security benefits says, your statements alone are not enough to establish that there is a physical or mental impairment. Well, there's the American Pain Society statement, and you can find almost the same statement in almost any kind of professional association that treats pain. It's not specific to the APS. The patient self-report is the single most reliable indicator of pain. A clinician needs to accept and respect this self-report absent clear reasons to doubt. Whoops. Right? Right, and this is one of the things that I am particularly interested in working on right now, the ways in which our social and structural stigmas are mediated by the laws and policies we make. And when I say laws and policies, this is a federal regulation, but I'm talking about health system policies, I'm talking about clinic policies, right? It's not just about laws, although laws are very powerful. It's also about policies we're setting in our organizational, our institutional lives from small to large. Right? And because stigma is scripted and it's hegemonic and it's often invisible, many times we don't see it. And there's no doubt that this impacts the lives of people in pain. The example I was talking about with a class, I teach a class on pain, and we were talking about this the other day, was the universal precautions approach, right? Opioid contracts, which is standard of care. It's become standard of care almost everywhere, even though we have very little evidence of actual efficacy. It's become standard of care. Right? And so one of the questions that I'm sort of going to leave you all with, and we can talk about it in the Q&A if you want, but it's one of the things my class and I were discussing, is to what extent does this policy, this has become a policy, it's become standard of care in most places that actually are still willing to prescribe opioids to people in pain, right? Does this particular policy, does it stigmatize? How would we know? We go back to the definition of stigma. Does it consist of an in-group marking and out-group as different on the basis of a shared demographic characteristic? And my answer to that is yes. And is there an assignation of deviance on the basis of that? I think there are reasonable people of good conscience can probably disagree, but I think it's an important discussion to have, right? So again, the ways in which stigma becomes scripted and integrated, okay? So what can we do? And I'll stop here. This is the last bit, okay? So usually what I say when I talk about pain and stigma is I sort of taketh away and then I giveth back. So taking away, part of the problem is stigma is structural. We can't fix it on the individual level. We can't. Having a good encounter, a good non-stigmatizing encounter with a patient doesn't resolve the upstream roots of stigma, although it's a good idea, and I'll talk more about it in a second, okay? But me giving back, the answer is, well, what looks like it has some effect in reducing the stigma that so many people in pain experience, right, as a result of not sort of having objective pathology that we can clinically correlate? And the happy answer is actually most things work. Educations, trainings. I work on some things related to policy development that systems and organizations and units can actually use to try to reduce the kinds of invisible hegemonic stigma that people experience. But what about on the individual level, right? On the individual level, because we can multitask. We can try to address stigma upstream structurally, and we can also try to do better on the individual level. So the first idea is to apply knowledge regarding the social patterning of behavior to clinical interactions, right? So the classic example I give here is of primary care providers, and this is anecdotal, but this just illustrates the point. Trying to treat people with type 2 diabetes, for example, and my prior appointment was in eastern North Carolina, which is very poor, very rural, very black. Okay, and it would not be uncommon for providers to have people come in to a diabetes clinic to have their H1AC check. And what are they doing in the waiting room? What are the patients doing? Eating what? Yeah, eating. In Eastern North Carolina, it would be Hardee's. Here it might be In-N-Out. It might be, they're eating fast food basically, right before they have their H1AC checked, right? And so this made the providers very upset. And then we started to talk a little bit about what are the kinds of factors that shape how different people in different communities eat, right? And we started to talk about what are the factors that might drive someone to eat these kinds of things before an appointment, right? Well, maybe they had to ultra commute to get there. Maybe they're working 2 different jobs and this was the only time they had to eat. They had to get something fast and filling and cheap, right? And you know what fills fast and filling and cheap? There aren't a lot of options, right? At least for people living in these communities, right? So they said that, for example, this changed the nature of their interactions, right? Then implementing anti-stigma training and programming, listening to people in pain. This is actually one of the most important things. People in pain report that that's actually the thing that they want most, right? That people, they are just not listened to. This is the number one complaint, of course, from American patients about their providers. That's been the same for almost 30 years. We've asked that question, right? Is that providers just don't listen. Part of the reason we know that providers don't listen is because they don't have time to listen. Right? So there are much, much larger system-wide and systematic problems that are going on here. That is making it very difficult to actually do good cognitive care and listen to people in pain, right? But people in pain often feel silenced and alienated. That's the experience of stigma. That's what it means to be silenced and alienated. And they experience this not just from providers and care teams. They experience this from loved ones. They experience this from other people in pain. I'm generally in favor of illness support groups, but the evidence for chronic pain is not that they don't work. They don't seem to work very well in general. Okay, so listening to people in pain and others describing their lived experiences as one is able, paying attention to social structures that sustain stigma, especially against people in pain, and watching out for implicit biases. Right? These are all things we can talk more about, and I have sort of lots to say about all of these things in general. So I'm going to stop here and leave the rest of the time for questions. Thanks a lot for coming and trudging across the street. I really appreciate it. Thanks. I think there's a mic making its way around. So.
Yeah, if you raise your hand, I'll bring the mic to you.
Thank you very much for your talk, Dr. Goldberg. I have a question about the patient's reporting of pain. And it's a point that goes to a distinction that was raised by Eric Cassell in the 80s, which is there's a distinction between pain and suffering. And it's really suffering that we ought to be concerned with because it's about the person's lived experience of the pain. And so I'm just wondering, do you address that in your larger research?
Yes, you have to. Almost everybody who studies pain agree. I mean, there are exceptions, but most of us agree with Dr. Cassell, right? Most of us think that there is a distinction between pain and suffering. They're not the same because there are people in pain who suffer, and there are probably people who suffer who aren't in pain, right? We know those kinds of things. So there is a distinction between those two, and I guess what I say is there's no doubt that for the vast majority of people who experience chronic non-malignant pain, there's suffering involved. It's true. It's not all of them. There are certainly some who suffer less, and there's varying degrees of suffering. So, but usually what I say, look, I'm comfortable saying that this is a big enough problem that we need to address it. And I'm comfortable saying that the majority of people who live with these kinds of things experience suffering of various kinds. What's also interesting to your point is notice, and this is well reflected in the literature on stigma as well, stigma is an independent form of suffering. Right? So for example, there's a well-known and a heartbreaking qualitative study of patients living with stage 4 lung cancer in the UK. And the study reports one of the most common things that the people say. They say something like, you know, this wouldn't be so bad if I didn't feel like I was constantly being blamed for my own disease. And I'm not a clinician, but from what I understand is if you were going to pick a list of ways to go, you know, metastatic disease from lung cancer would not be at the top of that list. That for many people who die this way, it's a hard death, you know? And the idea that there are people who say that dying a hard, difficult, painful death, say it wouldn't be so bad if they didn't feel like they were constantly being stigmatized, kind of wrenched me out of a state I was in at that time, right? Because it helped me realize that, wow, stigma is an independent form of suffering. So I guess what I'd say is, yes, we have to maintain that distinction. And yes, of course we need to focus on suffering. And we shouldn't collapse them. But at the same time, even if we focus most of our attention on suffering, we're going to get to a lot of people in pain.
Hi, Daniel. I wanted to see if you had thoughts about why Americans report being in pain more than our peer nations. I don't know if you know those data, but they're pretty stark.
Yeah.
So what is it about us that makes us, you know, kind of so susceptible to pain or more likely to report it? And then the other question had to do with, you didn't really touch upon this, but the role of criminal law as a stigmatizing mechanism, and what, just your thoughts about, you know, how that kind of intersects with your framework.
Leah. I knew I recognized you, Leah. I just couldn't tell where. So two questions. The first one is very interesting. I'm not sure why. You know, I think one of the tricky things about pain is we know there are significant social and cultural differences, right? Between society and culture has a huge influence on, you know, how you experience pain, what its meaning is, how you interpret it, how much of it you report. We know that those things are unquestionably true, but at the same time, you can get into some very, very dangerous stereotypes, right? And these have actually been well documented. One of the first books about people in pain that was actually written by an anthropologist was written in the 1950s, and it was actually called People in Pain by a Polish-American anthropologist. And it's problematic. I invite you to go back and read it. It has all sorts of stereotypes, like, so I'm Jewish, right? So Jewish people complain more about their pain than other groups, right? And Italian Americans say less about their pain. And he was documenting these things as an anthropologist, but he got into trouble. So I'm not sure why. You know, I think I would be willing to agree, or at least offer some tentative support for the possibility that there's something about American culture and society that makes us more likely to report our pain. I don't know exactly what that is or why it would be, but I'm willing to believe that. I'm not sure if I'm willing to believe that we actually have more pain than comparator nations. That's possible, but I need to see some evidence for that, right? So the short answer is I don't know. I don't know. I think it might be a reporting phenomenon, but I don't have good evidence for that, right? To your second point, the point about criminalization, and that's a huge factor in stigma. That's one of the major ways that we stigmatize people through laws and policies. There's arguably no more direct way to do it than to criminalize something, right? Than to say that this is the behavior under which, in which you are engaging, which used to be legal, or which, you know, is no longer legal. It is now worthy of criminal sanction. That's about as direct, right, a form of stigma and law and policy as we can possibly have, which is partly why people like Leo who are working so well on drugs and opioid laws are so concerned by efforts to criminalize some of these kinds of things, right? There's no question that it's stigmatizing people, right? And so there's a lot of theories behind that, the idea of the expressive function of laws and policies, right? That laws and policies express things. When we criminalize something, we're expressing certain attitudes and beliefs about people who engage in those activities, that they're worthy of censure and sanction, and in fact incarceration in the US, because that's usually what criminality means in the US.
I read a few things indicating that the drug companies made their money on both pain meds and sleeping meds starting in the 19th century. And that's what made them big and rich and famous, and that's what stimulated advertising. And that has played an important role in the fact that people express their pain because they get attention, and people people will try to do something to help them.
Yeah, it's actually funny. It's actually the beginnings of the modern pharmaceutical industry are actually connected to pain in a very important way. There's a good history here called Pain and Profits by Jan McTavish, who's a historian of medicine, and she talks about this, right? But what was the first patented pharmaceutical? Does anyone know? Some people know this. It was aspirin by Bayer, right? And so before Bayer patented aspirin, the most common way of marketing pharmaceuticals, these were patent medicines, is what they all were, is by claiming that this one patent medicine could fix all your problems. Good for gout and catarrh and all, and just the long list of, and dropsy and scurvy and I don't know, just name other 18th, 19th century diseases, okay? They were all down there. And so there was this long list of things that they would cure. So Bayer, when they actually patented aspirin, they decided to do something completely different. They decided to market their drug specifically for one thing only, and the thing they chose? Headache. It's quite brilliant, actually, right? Because how many people experience headache? Lots and lots then and now, right? So it was kind of a brilliant move, and it was extremely successful, and lo and behold, that's still how drugs are marketed today, to be honest with you, right? And so the story of drug marketing and pharmaceuticals in general, as well as intellectual property, is actually integrally linked to the story of pain. So yeah, you're right. That's exactly how these things come about. And there's all sorts of problems most people think with that approach. But yeah, that's how it happens.
Hi. I had a question around, in looking at this as kind of more modern medicine, what is kind of the correlation between kind of cultural, communal, indigenous medicine and kind of the more modern and technologized we've become as a society, especially in the United States? Is there any evidence or correlation between how pain was treated and the success of that treatment of pain when it was more community-based or more kind of one-on-one or integrated more maybe natural remedies and things like that versus now when there's an actual market for pain? Does that make sense?
Yeah, it does. I mean, I think it's a hard question to answer. I think there are some interesting studies of experiences and healing traditions regarding pain. There's a lot of evidence, of course, of healing traditions in general. Specifically focused on pain, I only know about a few of them. There's one that was really interesting that was done on the meaning of pain among the Yap Islanders in Polynesia. That's actually pretty recent. That came out in the last 5 years. That one's pretty interesting. I guess what I would say is, and this is a generalization, and without being a real expert on that particular question, what I'd say is I think the evidence suggests that the more pain is rooted in communities and that there is a larger body of resources and support with which to help people find meaning in their painful experiences and their pain, the more likely they are to feel better about it. Right? That doesn't mean, I'm not claiming that sort of, indigenous healing traditions have some sort of magic bullet that they can match their fingers and, people in indigenous communities just don't have pain, and the rest of us who live in sort of the technologized world, non-indigenous world, we have to deal with it. I don't know that that's true, but I think that it's generally true to say, look, the more social support you have and the more you feel as part of a community that cares and is trying to help you, I think it's pretty safe to say the better, the easier time you're going to have with living with that pain. That's the best I can do.
So recently I had occasion to read some Stoic philosophy for a presentation I was giving. And in the course of that, someone said to me that they thought it might be a good idea if we left in the waiting rooms of our ICUs the meditations of Marcus Aurelius. This actually might help some of our patients, or at least their families, cope with the experience that they were undergoing. Do you think is it obvious to you that we are a less stoic society than we were before? And is that a good thing or a bad thing?
Yikes. It's not obvious to me, and I'm certainly not the right person to say whether we are more or less or the same in terms of the stoicism. As to whether or not it's a good idea, I think that's an interesting question. I guess what I'd say is I think that that's dangerous when we start to think about power. right? I think it's perfectly fine. I have no problem with this, right? For a person in pain or a community that's trying to help a person in pain, right? If they say, let me see what this Marcus Aurelius is all about, right? He said you just kind of gotta, he had this huge philosophy which has influenced people for thousands of years. Let me look into that and see if that can help me. Great. I think that sounds absolutely fine. I'm less comfortable with it when you have a disempowered, often angry chronic pain patient, because we know that chronic pain patients are generally angry, and that's not a pejorative. If you know anything about the experiences of chronic pain patients, you probably understand why they're angry. It's actually an understanding thing. I get why they're angry. I don't blame them, right? But they often feel alienated and stigmatized, and I think there it's a little bit harder for me to countenance, a more empowered person like a member of a care team or something like that saying, geez, maybe you should look into stoicism as a way of proceeding with this kind of thing. I think that is not going to resonate well. So I think it partly has to do with where it's coming from and how it's being accounted for and delivered. But it could be, there's of course evidence that it helps a lot of people who live with illness and especially chronic illness. So it's not for me to gainsay. I just think we should be careful how we recommend it, I guess is what I'm trying to say.
So Dr. Goldberg, I'm conscious now of our time. Thank you very much for an extremely informative, challenging and erudite presentation. So again, can we show Dr. Goldberg our gratitude?